welcome to my channel. So if you haven't subscribe and hit the bell notification. So today we're going to be talking about the amputations. So objectives, we're going to cover anatomy, definitions, indications, types of amputation, principles of amputation, investigations, management, and complications as the last part. So the upper extremities, so we have the scapula, we have the humerus, and here we have the radius and the ulna, and the carpal bones, metacarpals, and the phalanges. So in terms of naming them as the upper arm, so the upper arm is also known as the brachium, which is between the shoulder and the elbow. Then we also have the forearm or antebrachium, where we have the radius and the ulna. Then we have the hand, where we have the wrists and the palm, which is made up of the metacarpus, and the fingers or phalanges. Okay, then the lower limb, the lower extremity. So this side, we have the hip joint, we have the pelvis, we have the thigh, we have the knee joint, we have the leg, we have the ankle, we have the foot, and the ankle joint. But on this side, we have the femur, patella, fibula, tibia, and the tarsals, metatarsals, and the phalanges. Okay, then definition of amputation. So amputation is the removal of a limb or other appendage of the body. That's just amputation. No need of you to put other things. And then amputation is the removal of a limb, so it can be due to trauma, medical illnesses, or surgical measures to control pain or a disease process in the affected limb, such as malignancy or gangrene. And in some cases, it is carried out on an individual as a preventive surgery for such problems. Then limbs such as arms, hands, fingers, legs, and toes can be amputated. Then indications, we have the famous 4Ds, which are deadly or dangerous, dead loss, and dead nuisance. But these are just to help you remember the exact examples. So dead, meaning the vitality of the limb or limb part is destroyed, and this occurs when there is arterial stenosis and occlusion to the blood vessels. So this results into tissue necrosis and eventually dry gangrene. Then under dead, we have for major or large vessels, where we have atherosclerosis and embolic occlusions. Then we have also for small vessels, where we have diabetes mellitus. So in diabetes mellitus, there is impaired circulation to the limbs, which occurs as a complication of diabetes mellitus. Then we also have Buerger's disease, which is a common finding in smokers, which is a disease that causes inflammation and blockage of veins and arteries of the limbs, where we have hypoperfusion to the affected limb, which leads to ischemia and eventually gangrene. Then Raynaud's disease under small vessels, which causes vasoconstriction of the blood vessels, resulting into ischemia and eventually gangrene. So that we are now done with the first D. So the second D is deadly or dangerous, or the amputation is life-saving. So a limb can be deadly or dangerous when severe infections such as gas gangrene and wet gangrene infect your body. So other examples, you can have neoplasms such as osteogenic carcinoma, extensive melanoma. So these are some disturbing pictures. Your aggression is advised. Okay. Then dead loss. This is the third D. So dead loss, this occurs as a result of severe lacerations, fractures, partial amputation due to trauma or burns, and severe contractures or paralysis, e.g. polio. And you can have severe rest pain without gangrene in a patient with ischemia. Then finally, the last D, which is dead nuisance, where we have deformed neuropathy. You can have polydactyly, severely impaired gait. So gait is the manner of walking. So when severely impaired, it's an indication for amputation. So the others are self-explanatory. Okay, examples of amputation. So we have raised amputation, which is an amputation of the toe with the head of the metatarsal. We have transmetatarsal amputation, where we have the amputation done proximal to the neck of the metatarsal, distal to the base. Then we have wrist fracture amputation, which is also known as tarsal metatarsal amputation. where we have the tarsal joint disarticulated with the volar flap. Then we have Chopard's amputation, also known as mid-tarsal amputation. Then the other amputations are marked by the pictures. You can pause and go through for the upper limbs and lower limbs, and we continue with the numbering. So we have also Sims amputation. We have which is the removal of the foot with the calcaneum and cutting of the tibia and fibula joint above the knee, above the ankle joints, with retaining heel flap, dividing both malleoli. Then we also have below the knee amputation. You can above the knee amputation, below the elbow amputation, above the elbow amputation, hip disarticulation. So for joints, we use the word disarticulation. So through knee disarticulation, hip joint disarticulation, through elbow disarticulation, shoulder disarticulation, those are terms. So in quarter amputation, the removal of one side of the pelvis with the innumerant bones, pubis, and muscles and vessels. Then we have interscapulothoracic amputation. Then finally, this is an important part where this is where we compare the old terminologies with the new terminologies that we are currently using now. Okay, so for the old terminologies, we have the partial hand, which is still being called the same. It hasn't changed. Nothing has changed. So still being called the same. So we have wrist disarticulation, still being called wrist disarticulation because of the terminology, which is new. Then you can have below elbow. So below elbow is still called disarticulation. Below elbow is called transradial. Then elbow disarticulation still being called elbow disarticulation. Then above elbow is being called transhumeral. Then shoulder disarticulation is still being called shoulder disarticulation. Then forequarter, still forequarter, partial foot. Then Sims is now being called ankle disarticulation. Then below knee is being called transtibial. Then above knee is being called transfemoral. Then hip disarticulation still hasn't changed. Then hemipelvectomy is being called transpelvic. So those are the terminologies we are using. Okay. Then types of amputations. So these are the types of amputations that we have. So for the types of amputations, we can have closed amputation and open amputation, also known as guillotine's amputation. So under guillotine's amputation, okay, so let's start with closed amputation. So closed amputation is an elective procedure. So we do it as an elective, and after amputation, the soft tissues are then closed primarily over the bone stump. For example, in more time, you can do above knee or below knee as a time-consuming operation. So you take your time and you make your stump and you close the wound. Then you can have amputation or open amputation, also known as guillotine's amputation. So guillotine's amputation, it is done as an emergency procedure. For example, in life-threatening infections, catastrophic trauma, such as in severe crash injuries. Then you can have after you do that, after the amputation, the wound should be left open and it shouldn't be closed. Then a guillotine amputation is typically followed with a more time-consuming definitive amputation, such as an above or below knee amputation. So we have two types depending upon the skin flaps. Then we have open amputation with inverted skin flap, which is a common choice. And we also have circular open amputation, where the wound is kept open and closed secondary by suture, skin flap, skin graft, or reamputation. So that's the other type. Then we have principles. So make sure you don't screw up amputations if you are to start doing. Then principles of closed amputation. So we are starting with principles of closed amputation. So we have tourniquets, which is desirable except in ischemic limbs. Then we have level of amputation, which is very important to fit the prosthesis. Then we have skin flaps. So you need to have a good skin coverage, and the skin should be mobile and sensitive. So these are the principles of closed amputation. Then for the muscle, you have to divide the muscle at least 5 centimeters distal to the level of intended bone section, and it has to be sutured. The methods of suturing the muscle, we have two. We have myodesis, where we suture the muscle to the bone. Then we have myoplasty, where the muscle is sutured to the opposite muscle group under appropriate tension. Then we have nerves, where you cut uh, proximally and allowed, where the nerves have to be cut proximally and allowed to retract. So you have to first uh, retract the nerve and you cut proximally so that it goes back in and it doesn't cause stump neuroma. So the large nerves are ligated before diversion. Then blood vessels, so you have to double ligate and cut. Then the tourniquet is released and the hemostasis is completed. Then for bone, the section above level of muscle section, that's the one we are supposed to follow, the section above the muscle, above level of the muscle section. Then drains have to be removed 48 to 72 hours. That's the Then for compression dressing, you can either use elastic or rigid plaster dressing fitting immediately. Then absolute bed rest is required with limb elevation, so this is acceptable for the conventional prosthesis with adequate vascularity. Then limb fitted, so the conventional prosthesis is fitted a minimum of 8 to 12 weeks after surgery. Then rigid dressing with temporary pylon prosthesis may be elected as an alternative. Then I also wanted to put something to remember the principles of amputation, so that at least you have ideas of or you start to have a visual on how to remember the principles we have talked about. So for the principles, you have to remember that these are for closed amputation and not for open amputation. So remember all the principles from bone, muscle, skin flaps, the tourniquets. You have to remember everything, because those will help you to differentiate, and also how to even cut blood vessels. You have to know that blood vessels have to be ligated at both ends, then you cut in between. Then for nerves, you have to retract them and you cut proximally so that they go back and they don't cause a stump neuroma. So that's the mechanism of as in why we are even doing the closed amputation in the first place. Then for muscles, you have to know the two types of suturing the muscle. So you can suture the bone or muscle to another underlying muscle group. So this is basically how the visual on how to do a closed amputation. So that's basically it, and you dress nicely, then you are done. Then principles of open amputation. So treatment following amputation, after you do an open amputation, you have to put a rigid dressing concept where you use the pylon, or where the POP cast is applied to the stump over the dressing after surgery. Then you can also do a soft dressing concept where the stump is dressed with the sterile dressing and the elastomer bandage is applied over it. Then investigations, so we have laboratory and radiological investigations. Under laboratory, you can do potassium and calcium levels, your full blood count, your blood culture, ESR. Then for X-ray, you can do for the geological, you can do X-rays, UAP and lateral review, CT scan, MRI, and Doppler ultrasonography. The management, you have to do your pain management, your wound care, and antibiotics to prevent infection. Then, of course, you have to start rehabilitations immediately after amputation. Then, where you exercise the proximal stump to encourage good circulation. Then, social and psychological care is important. Patients feel a sense of loss and grief when they lose a body part, and they undergo phantom limb syndrome. Then you have to examine the limb by comparing the two limbs. Then always do muscle power grading. So if you don't know how to do muscle power grading, you are in the right place. So let's go through muscle power grading. So muscle power grading of 0 to 5. So for 0, we have no movement, or where we have complete paralysis. Then we have for grade 1 or stage 1, we have flicker movements only. Then 2, we have movements possible if gravity is eliminated. Then stage 3, we have movement against gravity but not resistance. Then stage 4, we have movement against some resistance. Then stage 5, we have normal power, and normal power meaning you can push the an adult's hand away from wherever they are applying the pressure from. So that's normal power. Okay, then complications in surgery, know that complications are classified, so early, intermediate, and late. So early complications, we have the ones which are associated with spinal anesthesia, such as hypotension, failure to breathe because of the phrenic nerve is affected, then compression of the nerve causing paralysis. You can have surgical complications such as hemorrhage, hematoma. Then under intermediate complications, you can have wound infection, abscess formation, wound dehiscency, gangrene, DVT, pulmonary embolism, depression. And depression is very common. Then late complications, we can have pain due to unresolved infections such as sinus osteomyelitis and sequestrum. We can have bone spur. We can have scar adherent to stump. We can have phantom limb pain, ulceration of the stump due to pressure, hyperesthesia of the stump. Then that's all on complications. So let's just dive in deep with some of the complications. So for phantom limbs, you can have some amputees where they experience the phenomenon of phantom limbs, where they feel a body parts that are no longer there. The limbs can each ache and feel as if they are moving, and scientists have believed it has something to do with neural map that send information to the brain about limbs regardless of their existence. Then in many cases, the phantom limb aids in adaptation to a prosthesis, as it permits the person to experience proprioception of the prosthetic limb. Then how do you treat phantom limb pain? So phantom pain can be treated pharmacologically, where we inject with a steroid or local anesthetic, which has reduced the pain temporarily. Then you can have intrathecal or epidural anesthesia with opioids has been shown to be used successfully. Then for non-invasive such as US icing, TENS, and massage has also been used. The other methods, we have mild non-narcotic analgesics, can have biofeedback, psychotherapy, nerve blood and also rhizotomies have been used, but they have shown inconsistent results. Then we can have friction deformity as a complication. So friction deformity complicates the process of prosthetic fitting and ambulation. So we can have hip contracture and knee contracture. Then can also have new bone formation at the amputation sites, but this is common, or it has been reported that there has been new bone formation 5 weeks after electrical bends. Then you also have to monitor stump closely for tenderness, warmth, and swelling, and other signs and symptoms. Then such symptoms delayed fitting final processes. Then that's all on this tutorial. Thank you for watching. If you haven't subscribed, you can subscribe and hit the bell notification, and see you next time.